Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello, everyone, and welcome to this COVID edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. Since we're live, I want to remind everyone about how to ask questions of the speakers. Since the audience lines are muted, we don't take questions over the line. However, you all have the opportunity to type your questions into the question box at any time. We'll check for questions periodically and address them at the end of the session. Please don't feel you need to wait until the end before you start typing. Just go ahead and type them in as you think of them. We're delighted to partner today with SCIP, Solutions for Kids in Pain, to bring you Mobilizing to Virtual Care, experience of SickKids Chronic Pain Clinic. As many of you know, SCIP is a national network, one of Canada's networks of Centres of Excellence, or NCEs. We're working to bridge the gap between existing evidence-based solutions and patient care. SCIP is co-led by Dr. Christine Chambers at the Dalhousie University and Doug Maynard, Associate Director here at Children's Healthcare Canada. We're joined today by colleagues from our member organization, the Hospital for Sick Children, which nimbly pivoted their pediatric chronic pain clinic to virtual care during COVID. I'd like to welcome our moderator for today, Dr. Fiona Campbell, who will introduce our speakers. Dr. Campbell is co-director of the SickKids Pain Center and one of the leads of the Central SCIP Hub housed at SickKids. And it's my pleasure today to pass the mic over to Fiona.
Thank you so much, Paula. Good morning to most, and good afternoon and good evening to some. It is my very great pleasure to welcome you all to this very topical webinar, Mobilizing to Virtual Care, Experience of SickKids Chronic Pain Clinic. An enormous thank you to CHC for putting this on. Shout out to you, Paula, and also Anne Watkins for navigating us through this process. And thanks also to SCIP and Project Echo as key partners of the Pain Center at SickKids. I was reflecting with Doug Maynard recently that I might have been the very first presenter, along with Bonnie Stevens, of the then CAFC webinar series. And it is such a great testament that Children's Healthcare Canada continues to help us push the boundaries on improving pain management for children. Unless there are urgent clarifying questions for individual speakers along the way, we will save questions for the end of the webinar out of respect for all of the presenters. And a package of resources will be made available afterwards to participants, in addition to the webinar itself being recorded. And if there are further questions after the presentation, you can reach out by email, find me on Twitter, and we'll all be happy to help. Next slide, please. I am extremely proud and grateful to be the medical director of the Chronic Pain Clinic at SickKids. It's the largest such program in Canada, comprising a talented, flexible, truly interprofessional and cohesive team. It is my very great pleasure to introduce Lisa DAllesandro, one of our 4 APNs, Sarah Klein, one of our 3 physios, and Danielle Ruskin, one of our 2 clinical psychologists. They are all enormously talented, and their bios can be found on the webinar website. The speakers today truly reflect the interprofessional nature of our team. Someone from each of these 4 professions is on every single multidisciplinary team appointment, whether it be in person or virtual, and they have been 100% virtual. Next slide. Oh, sorry, disclose. None of us has anything to disclose. Next slide, please. So now that you know who we are, we would like to know who you are, and we'll pose this as our first polling question. We only have 2, but which of the following do you primarily identify with? We'll give you about 20-25 seconds to complete the poll, or until we see saturation, and then we'll have a little think about that. Thank you. So we have a fairly eclectic and broad group. So predominantly frontline clinicians, which is excellent. Some researchers, some kids and families, which is awesome. Managers and people, and a group of other. So what I can do, we can exit the survey result there. I do want to just say that I managed to extract a little more detail from the Excel spreadsheet of registrants. You are an eclectic audience. We're predominantly frontline providers, and having looked at this list yesterday, I know you reflect physicians, physios, OTs, psychologists, social workers, nurses, child life, dietitians, pharmacists, and care coordinators. We also have, in addition, most importantly, kids and families, but also people from senior leadership and other management roles. I also know that as of yesterday, there were just about 250 registrants, predominantly from Canada, but with a large number from the US, and also people joining from as far away as Brazil, Nigeria, and other countries outside North America. Next slide, please. Next slide, please.
Just bear with us a second.
Yep. So I can just begin to describe. The next slide is the objectives. And after this webinar, participants will be able to describe how to mobilize a clinic to virtual care, conduct a virtual pain-focused physical exam, and provide safe, pain-focused mental health care virtually. Next slide, please. So while we wait for the slide to come on, I can begin to provide a little context. I realize that not everyone on the call is necessarily a pain expert, so I'm going to just set a little context while you ponder the goals of the clinic, which will be shown on the next slide. Chronic pain affects 1 in 5, or about 2 million kids in Canada. It disproportionately affects those marginalized by social determinants of health. Chronic pain has significant impact on quality of life, sleep, school and sports, leaving kids socially isolated, and on mental health with high rates of concurrent anxiety and depression, and it doubles the risk of suicide. Chronic pain in teens increases the risk of substance use disorder and chronic pain into adulthood, which is a significant public health issue costing our economy about $60 billion per year. COVID has had a significant impact on kids living with chronic pain. While pain self-management is ideal, many patients still require tertiary services now more than ever. So as a team, from the get-go, we felt an urgent need to pivot to virtual care. I have to say, we had tremendous team buy-in in this transition. It is my very great pleasure now to hand over to Lisa, who's going to speak to you about the pragmatics of this pivot. Thank you so much, and next slide.
Thank you, Fiona, and thank you to you all for choosing to spend your screen time with us today. Moving to virtual care mapped nicely onto the hospital's 2025 strategic plan to transition to virtual care. Our intention was to move towards this over 3 to 5 years. However, with the introduction of COVID-19, the implementation of virtual care in our clinic was overnight. COVID-19 truly catapulted the pivot to virtual care. We are extremely fortunate to have a well-established telemedicine department and clinical experience working with both telehealth and the Ontario Telemedicine Network. OTN is part of Ontario's publicly funded healthcare system, connecting providers directly to patients in the convenience of their own homes. And it's the platform we have adopted in our clinic. When we reflect on the last 84 virtual clinics, there are a number of lessons learned that provide insight into the considerations choosing a virtual care platform, such as, is the platform authentic, meaning is there a governing body that validates its adherence to healthcare privacy legislation? Is the platform accessible? Is it easy to use? Does the service work on mobile devices? Is it available 24/7? How easy is it to connect? And are the font and graphics adaptable? Is the platform sustainable and integrative? Can it adapt to the needs of patients and healthcare providers? And does it integrate seamlessly with electronic medical record platforms? Finally, is the platform secure and is it private? How is the information stored? And are there strict data control measures in place? Once we moved in-person appointments to virtual care, our clinical workflow to booking patients was adapted. Scheduling of virtual visit clinics is managed by our patient care coordinator, and scheduling requests are built into our EMR platform. What we found invaluable is the patient education sent along with the email appointment notification. For example, the invitation email includes steps for a trial connection to test internet, camera, speaker, and microphone quality. This picture you see is a screenshot of our chronic pain virtual clinic with the patient in the larger screen and our healthcare team members along the bottom. So once we moved to a virtual care appointment, we noticed that we have a unique and well-established in-person clinic appointment that we found adapted quite easily to virtual care. The structure of clinic remained the same as shown in this diagram. We begin the virtual appointment logging into OTN. Of value is having the ability to lock out the patient from logging into the appointment during this time to ensure privacy while the team begins our case review. Once the patient is given access to the virtual clinic, we introduce ourselves and review privacy concerns before addressing health, pain, and psychosocial history, typically lasting about 40 minutes. In the hopes to provide a more intimate virtual appointment, we black out our screens while one care provider asks questions related to their specialty. For example, only the psychologist would be visual while reviewing the psychosocial history with the patient. Our physical assessment is conducted next, which Sarah will review in the following slides. We do at that point ask all care providers to black out their screens and mute their microphone for patient privacy. After completion of the physical assessment, we ask the patient to log out of OTN to join back after 15 minutes. During this time, we discuss diagnoses, recommendations in treatment, and next steps in care. Once the patient logs back into OTN, we disclose pain diagnosis and provide treatment recommendations. Our appointment is completed once an after visit summary is emailed to the patient. The summary outlines such things as recommendations on pharmacology, physical and pain treatments, pain and psychology treatments, along with a list of resources and next steps in care. I would like to introduce my colleague Sarah to review the virtual care pain-focused physical exam.
Thanks so much, Lisa. So here's a bit of an outline for the virtual pain-focused physical exam. We'll be talking about how to set the stage for both the healthcare provider and the patient, how we have implemented our virtual pain-focused physical exam for a typical patient over the last few months, and some ideas around physical therapy assessment and treatment done virtually. Next slide, please. So if we have the ability to communicate with the patient in advance, that's great. We can give them a heads up as to what we need. But if that's not possible, we can also make do and change around at the time when we see them. Having a private space for the physical would be important if it's indicated. Having them set themselves up so they're not in front of a window or a screen door, which can impede our view. Being in a place where they can leave a few feet of space between them and the screen so that they can stand and be seen head to toe for the exam. Having a maneuverable screen to get different views as well as a place to sit, stand, and lie down for different parts of the exam. Ideally, a laptop with a hardwire connection to avoid technical glitches. Some items on hand for sensory testing, such as a tissue, toothpick, pen cap, and a tape measure. Next slide, please. For the healthcare practitioner, we do want our devices set up a bit above eye level and pointing slightly downwards so it's not looking upwards into our noses. And even though it's tempting to look at the patient picture or our own picture when talking, we really want to be looking directly into the camera when engaging with the patient for better rapport. The lighting is better in front of us, not behind, so there's no glare. We try to limit noise through muting our mics when not talking and limiting background distractions. We also do give a disclaimer that the virtual exam is limited. If we feel that there's something important that needs to be evaluated in person, that we might ask them to come in person, or if there's an emergency, we might guide them to seek medical attention. We write that disclaimer in our notes as well. Just in case of technical glitches, we get a phone number so that we can call them back. Next slide, please. When speaking about moving to virtual care, I was quite concerned over not being present with my patient for the physical. As a physical therapist, I rely so much on my handling of the patient and my physical evaluation. But in reflecting with our team, we were thinking about how important really the interview and history taking is. We understand past evaluations, diagnostic testing prior to coming to our clinic for a pain-focused assessment. And we're also using the in-depth history to listen for red flags that might indicate further testing needs to be done. The history really drives the physical. We're really honing in on and assessing for type of pain, nociplastic, neuroplastic, nociceptive, as well as looking at the pain-related impact on their function. Next slide, please. So here's a general outline of what our pain-focused physical looks like. And today I'll just be going over a few tips and tricks that our clinic has been using to tailor it to virtual care. Next slide. So observation, we acknowledge, is a little bit easier to do virtually. So we're really looking intently at the screen to look for fear of movement, facial expressions, differences in affect. These can be seen on camera, give us a sense of how protective the body is. For inspection, we're asking the patient to bring the painful area up close to the camera, use their fingers to trace it so that we can zoom in and look closely. If it's a limb, we want them to bring both up side to side so we can get a good view. We can look at the skin color, quality, differences in muscle bulk, presence of atrophy. And if it's hard to see on the screen, we can ask the patient to send in a picture of that body part by email so that we can get a good look. Next slide, please. Typically in clinic, we would get the patient to do some gross motor movements. So we're finding that this also seems to get them comfortable on camera. So getting up, going from sitting to standing, walking further from the camera so that we can get a good head to toe look, perhaps doing some heel walking, toe walking, squatting. I often have to demonstrate the movement to show the patient what I want them to do. So I'm looking for quality of movement, signs of pain, hesitation, restriction. These movements can also give us some good information. For example, a squat, heel walk, and toe walk can give us some information about some of the lower extremity myotomes. In clinic, we typically do active range of motion and passive range of motion to get a sense of the independent movements versus the passive or assisted ones. Virtually, we've been observing symmetry of movement and, where appropriate, asking patients to do some passive overpressure to see if there is any more movement. Parents are also sometimes asked to help with the process. The PGALS is a musculoskeletal evaluation validated in pediatrics. We don't use this assessment, but I have seen it in practice to give a joint evaluation, and we are adding that as a resource for your information. Next slide, please. For strength, we typically do evaluate muscle strength using manual muscle testing, giving external resistance to various muscle groups. We've been asking the patients actually to do self-resisted movements, comparing side to side if possible, and they've been pretty good at articulating if one side is more painful or if they detect weakness one side versus the other. But I find, and some of my colleagues have found, that we've been using more functional movements to evaluate strengths versus resisted. So here's a list of a few examples. So doing a single leg stand side to side or a single leg bridge, you can detect if there's hip weakness side to side. A wall push-up, you can look at the scapula if there's winking side to side. So you can really get a sense if there's discrepancy in muscular strength side to side. And patients are also good at giving a verbal report as to what the movement feels like. Next slide. Palpation and cessation are also one of our hands-on assessment techniques. So we've been asking parents or patients to do it themselves. We would guide them to start on a neutral area with moderate to firm pressure, then moving to the unaffected side. And from there, I might ask them to start in an area away from the site of pain and slowly move towards it, and ask them if they're feeling any tenderness or increased discomfort. Sensation testing is the same, so doing self-testing to see if there's any pain with light touch, so a tissue or blowing on that part of the body, and increased pain with a toothpick. So we might start with a neutral area like the face and then compare unaffected and affected side. Landmarking can sometimes be challenging, so again, I would demonstrate on screen and then map out the area with them. Next slide, please. If the patient is seen for some extra physical therapy treatment, our exam would typically include a portion of the BOT2, an objective measure that's used to test components of gross motor function in children aged 4 to 21. It has a lot of time testing that's easy to observe on camera, like how many push-ups they can do in 30 seconds, how many crunches. We would also typically do a 6-minute walk test to measure endurance, but instead have been opting to have them measure out a portion of their room or hallway using a tape measure and then timing out how many links they can do in a certain given amount of time. For treatment, I've been doing a lot of demonstrating, so I bring the laptop down to the mat in my office floor, demonstrate the exercise or the technique. I'm also doing a lot of screen sharing to show them an exercise on a YouTube video or a picture of one that I can easily email to them afterwards. What's nice about having them in their home environment, our patients in their home environment, is that it's easy to translate what we do in session into what they have at home. So using their basketball net, their home equipment. Next slide. Pain education sessions are offered to the appropriate patients after their clinic visit. So we were offering these in person, a group-based session every 2 weeks in the hospital. We've now moved them virtually. It's increased our attendance and participation, and we give it a weekly group-based session via OTN, and we're soon moving to Zoom. Next slide. So just some safety considerations. The safety of our patients are paramount. So if I'm not there for physical support, I need to use clinical judgment when advising on what movement or activity I advise to do and ensure that proper supervision is present if needed. We know that this physical exam is limited because we lack certain parts of it that we need to be doing in person. It's definitely not a platform that works necessarily for everyone. It can be challenging with certain locations or certain populations. Next slide. That being said, there are a few benefits that we've been able to continue our care with our patients. It's taught me personally, and I think a lot of our team, how to expand our service if distance is no longer a barrier. We don't have that many no-shows. If someone does forget, we can easily get them on the screen within a few minutes, and it's taught me a lot about how to extend some of our care offerings, such as pain education, to become more accessible. I'm going to now hand it over to Danielle.
Next slide. Great. Hi, everyone. So I'm the psychologist on the team, and I'm just going to go through an outline here. So next point, please. So here are some of the topics I will cover. I'm going to talk about the activities of the health psychologist that were shifted to virtual care. Next. I'm going to talk about whether providing mental health virtually is on par to provision of in-person care. I'll talk about some opportunities that we've noticed while we're providing virtual care. And finally, I'll go over a safety protocol if you encounter any crisis or safety issues during a virtual session. Next slide. So here's some typical activities for the psychologist in our clinic that were transitioned completely to virtual care. The first one on the top left is the brief mental health assessment that are conducted along with 4 other members on the screen and the patient during our multi-D team assessments. The next activity are full psychological assessments. These are 2-hour assessments where I meet with a child or teen for a mental health diagnosis and a health psychology assessment, and parents join for the latter half of that assessment. We've converted all of our individual treatment psychology sessions to virtual care, and we've also converted our group treatments, including mindfulness and CBT workshops, to virtual care, and we use the Zoom platform for that. Next slide, please. So is virtual care for mental health the same as the real thing? Next slide. Not really. So let's go through a couple of reasons why. Well, the first one is that on these platforms, you see the gross nonverbals that are so important to mental health assessment, like interactions between a parent and child. You can observe eye contact, you can observe modulation of affect, but finer grained details that are so important are easy to miss. And an example of that is a parent disclosed to me that she was crying during a virtual session, and she didn't feel that the clinician had noticed that she had tears. And so, you know, I think these platforms are wonderful, but you really can miss those key nonverbals that are so important to feeling engaged with a therapist. Next. I've also noticed that teens are often looking over their shoulder during a virtual care visit, parents as well. They are worried that their family members might hear some sensitive information. So this isn't the same as seeing an individual in your therapy office shutting your door while a parent goes to the local cafe, and people can feel at ease to disclose sensitive information. This is not a deal breaker though. What I do in these situations, of course, is just say, why don't we do a phone call? Why don't you go out in your neighborhood and we can talk about these things, and people are much more willing to discuss that. Next point, please. So there are tech glitches. I know we all have experienced these. They do interfere with session flow. There's drop sessions, there's freezing that happens. Next point, please. And as part of our assessments in psychology, we do administer a battery of questionnaires, and we also administer these to obtain treatment outcomes for our patients. Typically, these are administered in the waiting room on iPads, and we can obtain these questionnaires in real time, but we're finding that our return rate when we administer these questionnaires virtually over email is just much lower. So that's, again, not a deal breaker. There's ways to deal with that. Next slide, please. Okay, there are new opportunities, though, that we're observing through providing virtual care. So we are seeing that individuals are using skills that we're teaching, like relaxation practice, mindfulness practice, directly in their home environments. They're lying down on their beds and doing a relaxation, and may be more likely to use these skills because they're practicing them in their homes. In some ways, the relationship at Therapeutic Alliance may be enhanced because we can see the patient's bedroom, they can see our house. We're sharing these intimate kind of details about our context that can really make us feel like we know each other better. There is immediate sharing of session content, which is really cool with the technology. So as I'm doing a cognitive behavior therapy session, I often use the whiteboard modality or even a Word document and type out patients' dysfunctional thoughts, type out some balanced thoughts, and I'm able to send them the session notes directly after the session. And we also use a lot of YouTube clips to illustrate therapy concepts. So the technology has opened up a whole new way of doing treatment. There's also increased uptake by our patients of group modalities. They're much more willing to sign up for our groups than when we used to offer them in person, probably because it's just so much less burdensome to turn on a Zoom session and then turn it off after the session is done and not have to come an hour, 2 hours down to the hospital. We also use the virtual breakout room feature in Zoom, which is really neat. You're able to do that, which enables you to pair up participants into smaller groups so that they can be put in virtual rooms to discuss a topic during a group therapy session, and then they can return to the main group. So that's a really neat feature of Zoom. And finally, On occasion, with some children, we use therapy dogs at the hospital to assist in relaxation or bringing comfort to pain. And during virtual session, we're seeing that children's pets are frequent visitors to the screen, and you can creatively use pets during your session. So it's really neat to see those opportunities. Next slide, please. So I will speak about handling safety concerns that can arise during a virtual session. But before I go into specific safety protocols for handling crises, there are two important considerations. First, you want to ask yourself, based on an understanding of this person's history and their presentation, to really think about, is this individual appropriate for virtual care? You want to assess orange or red flags, such as whether the individual has a history of becoming highly dysregulated. Do they have a recent history of acute crises like suicidal ideation or an admission for suicidal ideation? Do they tend to get aggressive? So those are situations where an in-person visit may be more appropriate than virtual care. Second, if you decide to proceed with a virtual care visit, you can take steps to optimize safety by doing some good prep work. Next slide, please. So prep work can include steps you can take prior to starting the virtual session. So ensuring a parent or a responsible adult is at the location of the virtual session for its duration, obtaining the contact number of a parent or an emergency contact prior to starting the session, and finally, reviewing limits of confidentiality at the start of the session so that people know that you may not keep things private. Next slide, please. Before I go into all the details of how to optimize safety, I want everyone to know that we are going to be including full protocols, step-by-step instructions for how to handle a safety crisis during a virtual care session in your resources for the webinar today. And these resources were developed at SickKids at our hospital in Toronto by a virtual mental health care working group composed of the Department of Psychiatry, Psychology, and Social Work. So first point is that if a child has some suicidal ideation that they disclose to you during their session, you really want to try to help that child disclose the suicidal ideation to the parent, and you want to create a safety plan. The next step is to provide family with a crisis line should any suicidal ideation or crisis occur between appointments, like the Kids Help Phone. If the child has active suicidal ideation, meaning that they have high intent to hurt themselves and they have a plan and they're not willing to disclose to a parent, you do need to disclose the suicidal ideation to the parent, and you should advise them to visit their local ER ASAP. If the child leaves the call, if they hang up on you, that's why we want to have that parent phone number. You need to call the parent and get the child back on the call. If the child is not going to get back on the call, you can assess their safety through the parent. And finally, if the child becomes aggressive, you call the parent. And if the parent, for some reason, is not present, you can always call law enforcement, 911, and remain on the call with the child. So these are some steps that we've outlined. Again, you're going to receive detailed protocols in your handouts. And I'm going to hand it back to Lisa.
Thank you, Danielle. Immediate to the introduction of virtual care clinics, the team developed and disseminated a survey to evaluate patient and family satisfaction with our virtual care clinic. This survey was built using scholarly material and in compliance with our provincial regulatory requirements. Dimensions of the survey include equipment and technical issues, communication rapport, and clinical assessment. On to our next poll, poll number 2. Of patients who have had both in-person and virtual appointments, what proportion do you think preferred virtual appointments? I will give you 10 seconds to guess. So on to next slide. High-level initial data reveals overall favorable results with virtual care by our clinic. Of patients who attended both types of clinics, 72% preferred virtual care appointments. Some high-level data reveals that 84% of respondents believe a virtual care clinic enables them to save time and money. 53% believe virtual care improves their ability to cope with chronic pain. 97% believe their privacy was respected. 93% had easy access to the technology. 84% believe the lack of physical contact in a virtual clinic is not a problem for managing their chronic pain. Of note is that in addition to patient and family satisfaction, we are now analyzing healthcare provider satisfaction with our virtual care clinic. I'd like to share with you that mobilizing our SickKids Chronic Pain Clinic to virtual care is demonstrated to be feasible, achievable, preferable, environmental. The healthcare industry itself is responsible for a large portion of public sector greenhouse gas emissions, of which includes the travel of our patients and staff to the hospital. And finally, sustainable. We will continue to track patient and provider adoption and satisfaction of virtual care while COVID-19 restrictions are slowly being lifted. The detailed description of our rapid mobilization of virtual care was recently accepted for publication. Effective teamwork is critical to implementing change, and we would like to acknowledge our entire team. We were nimble in adopting virtual care and remain creative in its delivery. Importantly, we did two key things. We identified a dedicated virtual care pain champion to lead this initiative, and we also substantially ramped up our communications to support these significant practice changes. For example, we quadrupled team meetings from month to weekly. We provided regular email updates. We created a WhatsApp group for in-the-moment communication. I would say a little bit of comedic relief. And finally, we kept very open lines of communication within the team. I will now invite Fiona to moderate questions that you may have of our webinar.
Thank you so much, Lisa. I wonder if maybe we'll even share our webcams so that you can see the team a little bit as we go. This is what we do during the clinic. We sort of go pop on and off, so it's a little bit less distracting, as people mentioned through the webinar. But I thought it might be a little engaging to see who we are, and shameless plug for SickKids on my t-shirt here. Okay, so thank you, Lisa, Sarah, and Danielle, for your fabulous presentations, very clear, and also to you, the audience. We do have time for questions, which was intentional, and we already have some questions. So I'm going to just float them out to whoever I think is best. All of you just muck in like we do. And the first question is from Laurie Pelosi, who was wondering a little more about the detail of how we get consent and discussing the limits of confidentiality, whether this is done before the session or, as Lisa mentioned, at the beginning of the session. So perhaps Lisa to begin, and then Sarah and Danielle, if you have anything to add.
Thank you, Fiona. So when the when OTN sends out the email for the virtual care appointment, in it, there is a disclosure of seeking consent to initiate the virtual care appointment. So that's the first, as soon as they click it on, they are accepting, there is an implied consent that is there. And then I'll hand it over to maybe Danielle to talk about the next consent.
Yeah, I think it's important to review the limits of confidentiality and consent at various time points. So for mental health sessions, we do send an email to parents ahead to get the phone number and to let them know they need to be there for the duration of the session, because they need to prep for that. And then we do let them know on the virtual care session, and the parent and child will meet together on the screen with the clinician, and we review the limits of confidentiality to let them know that we cannot keep things private if there are safety risks, and that we will need to contact their emergency contact or the parent. So we do detail it in an email prior, so they're prepped, and then we say it again in the session. And in your resources, you will have a letter to the parent that you could send that is already being scripted and has all these details that you could look at if you want to use that.
Sarah, anything to add from the physio perspective?
I think it's good practice just before every session that we do, just to remind them if there is a concern, or if they have a concern, you know, to seek attention. But yeah, that's it.
Just to add, we also have a pre-populated script within EPIC, which is our electronic medical record, our EMR, that we can add as a smart phrase into our note to read out. So it's documented that we have stated that. Thank you for that question, Laurie. The next question comes from Sarah Barker. One thing the OTN information seems to miss is that if families are using a cell phone, they seem to not be able to hear unless holding the phone up to their ear, which limits the visual assessment part. They are able to hear, however, if they use a headset or an earbud. I have my admin lets families know this, and it works well. Otherwise, audio problems are an issue. So thanks for that helpful tip, Sarah. And I just wonder if anyone has, any of you have anything to add about other tips related to the technology and perhaps the fallback position if all technology, video conferencing technology fails. So who would like to take that?
I can take that. So it is strongly recommended to our patients in the invitation email to have access to a computer. That being said, I mean, when we look at COVID-19 and accessibility of having computers at home and parents working from home, having access while parents are working and maneuvering for homeschool we have found a little bit difficult. So we find that our patients like, just wait a second, and they go onto their dad's computer and then go onto the mother's computer. So, I mean, it is highly recommended. If not, the helpful tip that one of the attendees just said, Sarah, was to have the cell phone, or perhaps if we're not able to obtain the information required to conduct the virtual care assessment, the physical assessment, and the psychology assessment, we will abort the appointment, the virtual care appointment, and reschedule at a later date.
Thank you, Lisa. If anyone, Sarah, Danielle, just put up your hand if you want to add anything else. I'll move on to the next question. The next question comes from Kala Balik. Thanks so much for doing this. Couple of questions. How long are you booking for new intakes, and how long for follow-up? And the second question is, are we willing to share this PowerPoint slide with other pain clinics? So maybe I'll take that one. Like we book an hour and 40 minutes, but really we should be booking 2 hours for the new patient intakes, and we book 45 minutes, but we probably need 1 hour, especially for the complex follow-ups. And I would say that we will be willing to share this PowerPoint slide, but if you can just give us a day or so to edit it to remove any personal identifying stuff that the co-presenters might not be want to share. But yes, absolute sure, we will we will be able to share these. Any other comments to that? Danielle, Sarah, maybe you could comment on how long you set for your individual treatment appointments.
Sure. I can mention for the psychology assessments, it's about 2 hours. Our group sessions are 2 hours of time with the patient, and the individual sessions are about an hour, but there's flexibility. One thing just to mention about the interdisciplinary team appointments is we always have, just as we do in person, sometimes, an appointment goes over, and families have been wonderful, and it's gone really well just to call them and let them know that we're delayed, we're a bit late, and can they come on in 10 minutes? It's worked really well, just as it does in person, except families can probably do a lot more at their house while they're waiting than they can in a waiting room. And I'll pass it over to Sarah.
Yeah, thanks. So we do 1 hour for physio assessment, 1 hour for treatment, and we've been doing 1 hour for the pain education session, which is a group session.
Thanks, Sarah. There's a question from Shona here, which I think probably is best for Danielle, which is how do you also be careful about boundary crossing?
That's a really great question. I think that is personal for different therapists. Some people are really don't share a lot of personal information. Others have, just as they do in their therapy office, have pictures of their families around their office. And so I think the big boundaries of not crossing into disclosing too much personally about yourself, having that internal compass that we have for in-person sessions is important. In my work, I'm just sharing my own opinion on this. Others may have different opinions, but in working with children and teens, sometimes disclosure is really helpful in the sessions. It helps to minimize the imbalance that can happen with a kind of a therapist or doctor and patient. So I think it's paying attention to your compass that you have anyhow in person. I don't think that really changes that much in virtual care, aside from what you're willing. You can see even my background here, you can see it's not a white wall, it's kind of details that you can tell a little bit about someone from the background. So I'd love to hear other people's comments if anyone else wants to share, or anyone else from our panelists.
So we have lots of questions coming in. We have about 10 minutes or so left. So if there aren't any more comments, I might just move on to the next question, if that's okay. I'm just taking them in order. So the next question is about whether we are using Zoom for healthcare or regular Zoom. We are not using regular Zoom. We are using Ontario Telehealth Network currently, but the plan is to use Zoom for healthcare. We do have an interim platform at SickKids, which is secure, but that is temporary, and we're moving to Zoom for healthcare. I think, Lisa, is there anything to add to that?
There was, when COVID-19 catapulted us into virtual care, there was many different platforms to consider moving our clinic appointments to virtual care. What we really wanted to do was make sure that it was a seamless transition, that patients and families were educated, and that there were materials already there developed in order so that we didn't have any gap in service. So I'm very happy to share with you that there was no gap in service. We went from 100% work activity in person to, on Monday, switching 100% of our activity to virtual care. We are excited that Zoom for Healthcare is being integrated, as Fiona said, into our EMR's platform. Once that is integrated, as I had mentioned before about wanting a seamless integrated product, we will be looking towards moving to that virtual care platform.
Thanks, Lisa. The next question is, how do we get an accurate weight for a patient if you want to prescribe medication? We just have to, well, we can look in the notes for previous patients to get, to see if there's a recent documented weight, but otherwise we'll just take it on face value and convert from pounds to kilos. Even though we all know our weights in pounds, it seems we only know how to prescribe in kilos, milligrams per kilogram. So we just take our best, most informed assessments. So we don't look at them, weigh themselves on the scale or anything like that. And I'm pretty confident that we are able to do this reasonably accurately. The next question comes from Laurie Henry to Danielle. It was problematic for patients not in clinic to fill out their questionnaires. What are some ways to help with adherence? And I think this is an important question, because if we don't begin to get good long-term outcomes on our patients, how are we going to know which treatments work best for which patients under which circumstances? So Danielle, over to you, a questionnaire question.
Such a good question, and it's so important. I mean, I think one of the things that we're thinking of actually changing in our service delivery is incorporating, so if patients complete questionnaires at the end of treatment to document treatment outcomes, we're thinking of adding a session at the end after that to give them feedback on their questionnaire responses, to give some incentive that these, that this is personally meaningful to them, that they'll be able to understand where did they progress, where did they have some areas that could still improve. And that might be reinforcing and an incentive and should be part of care. So that's a step that we're considering and moving towards. And I think the other thing is just once you have a relationship with someone, it's hard in the assessment, but to really emphasize as much as possible how important those questionnaires are for the assessment. You could use other strategies like not booking the next appointment until they've completed the questionnaires. We're finding that we can book patients fairly quickly. There's 1 to 2 week wait, so it's not an ethical concern if we had to delay a session until we receive those questionnaires.
Thanks, Danielle. The next question comes from Kathleen Lynch, who works in the Pediatric Chronic Pain Network in Ontario. Hi, Kathleen, thank you. It's clearly popular for patients to have virtual clinics, virtual visits, but do you feel your success rate is similar? So I'm thinking that this refers to our outcomes. So we do collect data on outcomes, so we will have a look at that in a minute. I just want to reflect back to the second poll question, because we didn't look at the graphic result, I don't think. We may have just skipped over that, and I don't know if you can see the result in the poll section, whether everyone sees that or just we do, but you, the audience, assessed that 10% of you thought that about 25% of patients would prefer virtual care. About half of you thought that half of patients would prefer virtual care. 37% of you thought that 75% would, and no one thought 100, and I guess that was kind of unreasonable. Nothing's ever 100%. But it is interesting that we're at the response rate was 75%, approximately, just under that, preferred virtual care. So I don't know if Kathleen's question was, do I think that other clinics would have the same patient preference rate, or whether it's about outcomes. But I will hand that over to Danielle and Sarah, and Lisa, if you have anything to add.
I do. So thank you for your question. We're very pleased that we started a patient and family satisfaction survey from day one. So everyone who has received either a follow-up or a new appointment has been given the opportunity to complete this survey. The intention is to track satisfaction results over time as COVID-19 restrictions are lifted. So if you're given the opportunity, so I'll hand it over to Dr. Ruskin to explain a little bit more about some of the outcomes data that has been collected based on in-person treatments. But I think, actually, I'll transfer to Dr. Ruskin now to talk about the next steps in gaining insight into virtual care treatment outcomes.
I'll just add briefly, we do have a small grant looking at this question that we will be able to provide some data. We're going to be comparing a matched sample of kids who received virtual standardized physio, psychology plus or minus medication, occupational therapy to a group that received in person. And we'll be getting those findings out soon.
Thank you. You know, we have about 5 minutes left and quite a few questions. I'm just going to address a couple of them quickly as we go, and then maybe have some for discussion. So a question about consent. So what age would you consider just getting consent from the teenager? So generally speaking, there is no age of consent. It's really capacity to understand, and I think that's what we go by in our clinics. The next question is around, are patients prevented from recording the session? So I don't believe that patients are able to record our session, but maybe I'll just hand that over to our tech expert, Lisa, and Danielle and Sarah for that matter. So what's the scope? What's the scoop on whether patients can record?
Other than if they do it from a separate device, do they have the chance to? Yes, but through our virtual care clinic itself, through that platform, they do not.
Thanks, Lisa. A question about how we communicate with each other during the clinic. And this is a very pragmatic question. It's, do you text each other during joint sessions to keep flow of sessions, and is this a privacy issue? So it is a privacy issue, although we use Microsoft Teams at SickKids, which is a secure platform that we're able to communicate with each other on. SickKids also approved WhatsApp during this kind of exceptional time. So we have different WhatsApp set up so that if you suddenly urgently need in the moment communication, we will use that. We tend not to text each other, and if we do not mention patient names at all. So we use a variety of techniques, but I would say the Teams chat is the one that we have tended to go to because it's hospital sanctioned, secure, and we all have it. There's a question for Sarah from Laurie Pelosi. Thanks, Laurie. Sarah, have you adapted the pain education workshop in any way for the virtual audience?
So the pain education workshop is a constant kind of evolution, and we're always looking to change it and involve more dynamic and kind of involving the audience. We haven't adapted it yet. We still are giving the same exact workshop that we did. One difference is that when we did it in person, we had the parents and caregivers separate from the patients after we did kind of our neuroscience spiel, so that we could do some more, closed small group session and interactions with the patient. So we don't have that opportunity now. Instead, we just give it all with the patient and the parent there. But patients still seem to be engaged and involved and enjoying it, but we're always looking for new ways. And I think with Zoom, when we can do breakout groups, that might be more feasible. So we're looking forward to that.
Thanks, Sarah. You know, we have come to noon. I'm going to ask you not to post any more questions in the question box. We do have 4, and I think we can address these quite quickly if people are happy to stay on. Certainly, I'm very mindful of people's time and Zoom meetings and so on, so hop off if you need. We'll probably be able to wrap this up in the next 5 minutes. So the next question comes from Stephanie Sullivan. Thank you, Stephanie. Is a referral to the pain clinic within scope of practice of a nurse or a physiotherapist, or will a physician order be required? And then she says, SickKids shout out. So I'm going to hand that to Lisa, who does the triaging.
Thank you for your question. Just to clarify, Fiona, is the question relating to can a physio or nurse refer? Absolutely, yes. And quite frequently we do have referrals coming from, for example, SickKids Rheumatology, where there may be a pre-appointment with an advanced practice nurse who will do a physical assessment and then either book with rheumatology or send in a referral to the chronic pain clinic. So yes, it is within scope of practice within SickKids for our allied health to send in a referral.
The next question is whether we have an occupational therapist on our team, and the answer to that is a resounding yes. She's a critical component of our team. Her name is Shireen. We would be happy to connect you if there are occupational therapists out there that wish to discuss scope and her role on the team. Thank you for that question. Question from Navreet Gill. How has the switch from in-person visits to virtual visits impacted the clinical workload for the team? So I would just take a stab at this and say, from my perspective, it is about I would say it's about the same for me, but I'm really mindful of the knock-on effect of people who are in the clinic day to day. Like, I have my clinical operating room work and I think I'm protected. So I'm going to hand that one over to Lisa as well, and the others may have something to say in terms of their workload as well. Thanks, Navreet.
Thank you for your question. I would like to acknowledge our administrative staff, as it is I'm pretty positive, confident that their workload has greatly increased. There are a few more steps to booking a virtual care appointment that are involved in this. So a big shout out to our staff for making that happen. Susan, I'm speaking to you, and Kara and Bryna. So, but I also would like to note that in my personal practice, I am noticing more of a reach out from patients and families through connecting through virtual care. So requesting a virtual care appointment. I think that what's happening with COVID-19 is that they're not able to reach the family doctor, yet we're more accessible. So we're getting a lot more clicks. Danielle?
Yeah, I would say there's the confounding factor of working from home and virtual care, because there's so much more energy of accessing the medical record, accessing patient appointments, and then doing the virtual care session. So I do feel workload has increased most definitely because of just navigating all those things that if you're in the hospital, they're there, but they're just so much easier to have. So that has been my observation. The other thing that I think Lisa might have put in her slides is our no-show rate and our cancellation rate has gone way down because everyone is coming to their appointments. So it's wonderful, but it is something that was present as part of our day in the past. It's not great, but it is that you're constantly scheduled. So Sarah, anything you want to add?
Yeah, the fact that people are available right now means that we're kind of stacking right through the day, as opposed to maybe being a little bit heavier on the bottom when patients would leave work and school. Also, previously, if we would have appointments where if someone needed to come psychology and physio, it would be kind of that matching of the times, which would maybe make their appointments a bit far out. Now, to the benefit of the patient and to the care, you can see multiple providers, Monday and Wednesday. It doesn't have to be on the same day. So it does mean just that our schedules are a little busier.
Thank you. And then there is one final question, which is slightly on a cautionary note. I'd like to finish with something extremely positive, but the comment is, I think we have to assume that clients are recording. So they might not be recording directly from the platform, but maybe they are recording directly onto their own devices. And I think that is, we probably can't mitigate against that. It's just like when they come into a clinic, if they choose to record, that might be the case as well. So just people need to be cautious. We all should be professional and be able to stand by what we're saying anyway. So hopefully we have nothing to be concerned about in terms of that. But I think that is a really good point, and thank you for bringing that to our attention. Okay, yeah. I'm going to wrap it up. We've gone over. And thank you to everyone who's remained on the line. Thank you all for your attendance. Thank you to our incredible team at SickKids. And Lisa shouted out a few people who hadn't been mentioned along the way. None of this would be possible without any of the people on this slide. And so thank you all. And again, thanks to Children's Healthcare Canada, SCIP, Pain Centre, and Project ECHO for really helping promote this and partnering with us on it. Thank you, and do reach out to us if you have any questions about anything at all. This is the way of the future. It's what patients want, children and families want. It may not be for 100% of patients, but I really think that we're going to have to embrace this. Thank you all so much. Have a great afternoon or evening, wherever you might be. Thanks.
Thank you, Fiona, Lisa, Danielle, and Sarah. Thank you to all our attendees for your interest in the webinar, despite all of our Zoom fatigue. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. However, during the COVID pandemic, we are offering some special editions of our knowledge sharing opportunities, and these may fall outside our typical webinar slots. To stay up to date on all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you have not already done so. It's always great if you can watch live, as your questions and comments really enrich the discussion, but if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. We also have another webinar coming up on Friday, June 5th, Living with COVID, Building Pandemic-Informed Approaches to Support Our Child and Youth Mental Health, featuring colleagues from BC Children's Hospital. And next week, we have 2 more scheduled webinars, Kids Sim Mobile Outreach Education Program from Alberta Children's Hospital on Wednesday. And on Thursday, June 11th, we're partnering with, it's partnering during a pandemic related to Children's Hospital of Eastern Ontario's Family Engagement and Partnership during COVID. So thanks again for joining us today. Thanks for Children's Healthcare Canada partner, SCIP, and members, SickKids, for supporting our webinar program. And hopefully we'll see many of you back here on Friday. Bye, everyone.